recognizing the problem is only the first step. There is a big gulf to solving the problem. And the big gulf is there a solution that we can all agree on? That is our big challenge, yours and mine. And that's really where we're falling down in the country. We don't have a solution that has widespread agreement. Now, before I talk about the various options out there, including our own proposal, I want to make one very important point. As the presidential debates evolve, and as we move into 2009 and we discuss health care reform, there is one very important criteria you should use to evaluate every proposal that you hear about. Real reform, sustainable reform that'll last, has to reform not just how we pay for health care, but also how we deliver health care and health care services to people. It's not good enough just to change the amount of money or getting everyone in the system. We have to change how we deliver care. And so you ask of every proposal, how does it change financing? How does it change the delivery system? What are the incentives it's putting in place to change the delivery system? And unfortunately, most of the debate in this country at this time is about changing the money part and not changing the delivery system. And that makes it unsustainable. So you ask about the candidates' proposals regarding the financing, but also regarding the delivery system. All healthcare reform boils down to one of four possible options. Now there are, if you listen, hundreds and hundreds of permutations, but each of them can be classified into only one of four categories. There's incremental reform. We can't do the whole thing. We have to do small changes. I don't actually really consider that reform. We've been doing that since we instituted Medicare and Medicaid in 1965. That is business as usual. If you think the healthcare system is working well, continue with business as usual. But it is not going to solve the problem of access. It's not going to solve the problem of cost. It's not going to solve the problem of quality. As I said, I don't consider it real reform. It is really just continuing on the same broken path. The second option is mandates. A mandate for individuals or a mandate for employers to provide health insurance to their workers. This is what they've done in Massachusetts that's gotten a lot of attention. It's what Governor Schwarzenegger tried to do in California, although it wasn't enacted. And basically it requires people to get insurance. It sets up a market, an insurance exchange, where all the insurance plans have to offer the same coverage at the same price. And then because it's requiring people to get coverage, it provides subsidies to people to buy that insurance, usually up to $60,000 for a family of four. Now, I have great admiration and respect for the man who came up with the Massachusetts plan, a professor at MIT called Jonathan Gruber, who's a very, very smart health economist. And as I say, I have enormous respect for him. Unfortunately, mandates, the Massachusetts mandate plan, does nothing about the delivery system. It's really focused on getting as many people into the system as possible with as few changes to the current system as possible. And that's its Achilles heel. It's its virtue. If you make few changes, you can get a lot of support, but it's also what makes it unsustainable in the long term. Because it does nothing about redoing the delivery system, it does nothing about quality, and most importantly, it does nothing about cost. And if you don't do something about cost, you cannot sustainably have universal coverage. We just can't afford it at the prices escalating today. So I think while Massachusetts is a very wonderful experiment, it is not going to succeed, and it is not sustainable because it doesn't do much about cost. The third option is single payer. Medicare for all, the Canadian-style single payer plan. And single payer advocates look at insurance companies, look at drug companies as taking way too much money, not providing a lot of value to the system, and they argue, first, we should have a national plan that provides everyone needed care. We should get rid of the insurance companies. Second, we should have a fixed fees, and the government control the fees so that they can negotiate with the drug companies to lower the fees on drugs. They can negotiate with doctors and hospitals to adjust the fees and keep costs down that way. And third, that we should have very low administrative costs and save a lot of money on the administration. If we don't have insurance companies, we'll be able to have low administrative costs and therefore cover the uninsured. My own assessment of single payer is they've got the most radical reform of the financing system, and the most antiquated view towards the delivery system. They basically want to keep the 19th century fragmented horse and buggy system we have in place. And they keep it in place by having this fee-for-service payment system and not really changing it. And again, over the long term, it does nothing about cost control, and I think is unsustainable. I also personally think, since enacting any plan is going to require bipartisan support, it's not a viable political plan. You're just not going to get people on the other side of the aisle or even conservative Democrats to endorse single-payer plans. And I could go on about some of the other reasons that I think it's not a very viable plan. So what's my alternative? The fourth alternative, as we outline in the book, is called guaranteed healthcare access. And the best way to understand it is that it's really composed of 10 simple planks. First, and most importantly, every American and American family receives a certificate to obtain a standard healthcare benefits package from a private insurance company or health plan. This isn't a cash certificate. It's not like an ATM card where you charge your MRI scan or you charge your blood test. You get a certificate to get a health insurance package. The health insurance package, the standard package, is modeled on what congressmen and senators get, the Federal Employee Health Benefit Plan. At the moment, that plan is pretty good. It's better than about what 85% of Americans get. It's certainly better than the Medicare coverage. Insurance companies and health plans are required to enroll any person who presents them with the certificate. They can't exclude anyone with pre-existing conditions, and if someone wants to stay with them year to year, they have to guarantee renewability. So there's no trying to avoid the sick or dropping someone who develops cancer or heart disease. Finally, to encourage them to take care of the sick, they actually get paid what we call a risk-adjusted premium. That is, they get more money for taking care of sicker patients and less money for taking care of the young, healthy. That's the first point. Second, most Americans would have free choice of a health plan from among 5 or 8 choices in a major city. New York, there might be 20 choices. Rural North Dakota, there's likely to be only 1 choice. If you don't choose, you're actually randomly assigned to one of the health plans by a regional health authority. Third, these certificates or vouchers that you buy insurance with are funded by a dedicated value-added tax, a VAT. Without Medicare and Medicaid in the system, the VAT starts at about 10%. With them enrolled, it would be about 15%. Dedicated means it only goes to health care. It doesn't depend on annual congressional appropriations. But dedicated also means it doesn't take general revenue from other services over time. We have to live within the budget created by the value-added tax. Fourth, Americans have freedom to purchase additional services. If they want something beyond the standard benefits package, better mental health benefits, they want a wider selection of doctors or hospitals, they want to be able to go to any doctor in the country if they get some serious illness like cancer or multiple sclerosis, they can buy a supplementary insurance package and pay for that themselves. Fifth, private insurance companies, private health plans, private doctors, private hospitals deliver the care. This is not a government-run socialized medicine practice. Sixth, the great tax benefit that almost everyone in this room probably receives from their employer to get insurance is eliminated. So employers no longer have a financial incentive to provide insurance, and workers then would go into this guaranteed healthcare access plan. Seventh, Medicare, Medicaid, and other government programs would be phased out. What do I mean by phased out? We wouldn't just shut them down. People who are in the programs would continue in the programs, but there would be no new enrollees. Someone who turns 65 next year would not go into Medicare, but would stay in their guaranteed healthcare access plan. Over about 10 to 15 years, those plans would be phased out and everyone would be in one plan for the whole country.